Sir, we are initiating
So-
in another 10 seconds, then we will be having a chat.
I think we are live now. It is showing live.
We are live, sir.
Sunilji, should we initiate?
Yes, sir. We are live, sir.
Okay. So, good evening and welcome to the very first episode of All India Postgraduate Teaching Program, which is a new initiative from ARC, wing of All India Ophthalmological Society. AIOS is the largest society of ophthalmologists in the world with more than 26,000 members. More than 2,500 postgraduates are joining ophthalmology in every academic year, with more than 300 hospitals offering post-graduation in ophthalmology. But there is a disparity in the infrastructure and the teaching curriculum, and that was a matter of concern. And that's why it was a dream of our president, All India Ophthalmological Society, Dr. Harbansh Lal sir, to initiate a postgraduate program to address the above issue. And he shared the above challenge with the team ARC. With so many national and state level postgraduate programs already in vogue, the challenge to team ARC was to fill up the lacunae and create a program with difference, which would definitely be adding more to the postgraduates. So we decided to look into the uncovered aspects of teaching programs like case presentations, journal clubs, OSCEs, and didactics on topics which are not very well comprehensively available in textbooks. Thank you, President Sir and GC for entrusting this responsibility to Team ARC. So here we present our first maiden episode of the series. Today's the long case would be presented by Dr. Aishwarya Palpati. She's a second-year resident from RIO Chennai. And we are equally thankful to mentors, Dr. N. Sharmila, who is professor and head of glaucoma services at RIO Chennai, and Dr. Sharmila, who is additional assistant professor at RIO Chennai. You must be wondering how did we zero upon the RIO? RIO is the oldest teaching postgraduate institute of our country, and that's why we zeroed upon it. And we are thankful that the director, as well as Professor N. Sharmila and Dr. Sharmila, both of them agreed to be the part of this episode. My special thanks goes to Dr. Krishnadas sir, Dr. Nayak sir, and Dr. Shalini Mohan ma'am for consenting to be an examiner today. Now I request our president of All India Ophthalmological Society to address the postgraduates in few minutes. Harbansh Lal sir.
Yeah. Thank you, Prashant Bhavan for initiating this program. So this was my vision statement and in my presidential speech also, that we want to really strengthen the postgraduate teaching program. And we thought no better than the ARC should take up this challenge, because that is primary responsibility of the Academic and Research Committee to look for the PG teaching. At the same time, actually it is just the beginning, and the training the teachers program or training the trainers was also the part of this. So I think we are not be able to put into the place. We wanted to rate the presentation and the teachers, and then we can initiate the Dronacharya Award and Arjuna awardees for the best student and the best teachers. And the 10 top teachers selected from the country will train the other teachers in the country. So maybe the IOS will sponsor the full program of 50 teachers coming at one place and sharing how to go ahead and strengthen the teaching program in all over the country. So that is the idea. Nevertheless, because the time is short and we want that the program which should get started, and as over the period of time, I think we will keep on improving and the things will keep on becoming better and better. So I think as such, so far as the postgraduates are concerned, I think this is the best time for the postgraduates for learning, because there is so much of material available online and on the web. But at the same time, they should not forget that the basic teaching is when you see the patients, when you talk to the patients, when you talk to the mentor, that can never be replaced by these webinars. So if you're not put in your work in the hospital, if you don't take care of your patients, if you don't talk to your mentors, if you don't talk to your teachers, if you don't take your problems to them, you are never going to learn. So all those students who really come and talk to you, all those students who are interested and those who respect their teachers, they actually learn the best. You can't give anything to the teachers except the respect. So many of the students, if you don't respect your teacher, you are really not going to get anything out of them. So I request all the postgraduates to really respect the teacher in the institution they are working, and we really go and talk to them and discuss their problem. Do not try to put the things under the carpet. You created a complication, and do not hush away the patient. You must show it to the teacher or the other surgeons and get it properly corrected. So with these words, I like things to proceed further and request Prashant Bhavanpule to go ahead.
Thank you, sir. Thank you for those and highlighting the importance of Guru Shishya Parampara, which is a core strength of our Indian teaching program since ages, I should say. Now it's my duty to hand over the proceedings to Dr. Anaga, who is member ARC West, and Dr. Deepak Mishra, member ARC Center, to carry forward the proceedings for today's episode. Over to you, both of you.
Thank you, sir. Thanks a lot. My duty is first to introduce all the what we have planned. Basically, is we planned in such a way that like the PG examination will be going on in any place. There will be some internal examiners and some external. For the today case presentation, the internal examination is Professor Sarmila ma'am, and again Dr. Sarmila, and the external examiners are like our expert or examiners is K. Krishna Das sir, Dr. Nayak sir, and Dr. Salvi Mohan. So although all the three external examiners need no introduction to anybody, but since Prashant sir has given me job, so in briefly I will tell one or two line about them for our audience. First of all, Dr. Krishna Das sir, he is a senior glaucoma consultant and PG teacher at Arvind Eye Hospital, with you can imagine the 3 decades of the experience in the postgraduate trainings and fellows in the glaucoma. I think a lot of them have joined here. We welcome you, sir, Krishna Das sir. Next, our external examiner is Dr. Barun Nayak sir. He is professor and HOD at Hinduja Hospital, Mumbai. He is the past president of AIUS and also the present president of Glaucoma Society of the India. He is well famous for his talks and lectures on the visual fields and other things. Welcome, sir. And our third examiner is Dr. Salvi Mohan ma'am. He is also a professor and head ophthalmology at GSPM Kanpur. She is presently the president of Kanpur Ophthalmic Society and editor of UP Journal of Ophthalmology. With these short introduction of our experts, I request Dr. Naga ma'am to introduce internal and proceed further. Thank you, sir.
Thank you, Dr. Deepak. A very warm welcome to everyone here and welcome to the first episode of the ARC PG programs. It's an honor for me to introduce our mentors for the day. Dr. V. Sharmila Devi ma'am. She is the Senior Assistant Professor of RIO GOH of Chennai, Joint Secretary TNOA, immediate past editor, Tamil Nadu Journal of Ophthalmic Sciences and Research, and extremely well trained in glaucoma and cornea. Welcome, ma'am. I would also like to welcome Dr. N. Sharmila ma'am. She is the Professor of Ophthalmology, Regional Institute of Ophthalmology and Government Ophthalmic Hospital, Chennai. Graduated both undergraduate and postgraduate from the prestigious Madras Medical College. Working in the field of glaucoma for the past 25 years. We have a huge experience today, ma'am, and thank you so much for being here. She has a great passion for teaching and training students in ophthalmology, published many research articles in national and state level journals, and at present striving to bring residents Journal of Ophthalmology from RIOJ Chennai. Thank you so much, ma'am, for being here.
Thank you.
And it's also a great pleasure for me to introduce the star of the day today, our resident, Dr. Aishwarya. She is the second-year resident of RIO GOH and aspiring to see the world within the eye that sees the world. So over to you, Dr. Aishwarya. All the best to you. I'd like to request you to please start your presentation. Please unmute yourself.
Thank you, ma'am. Thank you for the kind introduction, ma'am. Good evening to everyone. It's an honor to present my cases in front of all you esteemed professors. I'll start the presentation.
You have to be a bit loud and discreet, Aishwarya. Okay?
Yes, sir.
Okay.
Shall I start the presentation, sir?
Please.
Yes, please start.
So without further ado, I'll start my case. This is a long case on glaucoma. A 69-year-old male came with complaints of defective vision in right eye for the past 6 months, which was gradual in onset, progressive in nature. There is no history of pain, redness, or watering. There's no history of photophobia. There's no history of glare. There's no history of colored halos. There is no history of frequent change of glasses. There's no history of difficulty in dim light adaptation. There's no history of headache. Past history, patient had history of left eye, phacoemulsification with foldable IOL, with trabeculectomy, with mitomycin C, with releasable sutures, done 2 months ago at RAO GOH. Patient is not on any medication currently. Patient is on Bimodin and Timolol eye drops in right eye twice daily for past 4 months. There's no history of diabetes mellitus, hypertension, bronchial asthma, coronary artery disease, or thyroid disorders. There's no history of ocular trauma. There's no history of food, drug allergy. Personal history, patient consumes mixed diet. Patient has history of tobacco and alcohol consumption occasionally. Family history, there's no history of similar complaints in the family members. General examination, patient is conscious and oriented. He is moderately built and nourished. There's no pallor, icterus, clubbing, cyanosis, and regional lymphadenopathy. The pulse rate was 86 beats per minute. Blood pressure was 130 by 80 mm of mercury. Systemic examination showed cardiovascular system, respiratory system, abdomen, and central nervous system findings were found to be normal. Ophthalmic examination. Head posture was normal. There was no facial asymmetry. Eyes appeared orthophoric. The anterior segment examination. Right eye showed lids and adnexa were normal. Conjunctiva was muddy. Cornea was clear. Anterior chamber showed one headed grade 2 to 3. Iris color pattern was normal. Pupil was 3 mm, reacting to light. Lens was grade 2 nuclear sclerosis with posterior subcapsular cataract. And extraocular movements of the right eye were full and free. Left eye, lids and adnexa showed normal. Conjunctiva showed central, flat, avascularized bleb present superior to the limbus from 12 to 1 o'clock position. Movements grade was diffusion 25%, low height bleb with avascularity. Conjunctival sutures are present. Cornea is clear. Antechamber shows one-handed grade 3. Iris color pattern was abnormal as there's a patent PI at peripheral iridotomy at 12 o'clock position. Pupil are 4 mm reacting to light. Lens was posterocapsular IOL. Extraocular movements were full and free. Ocular parameters. Best corrected visual acuity of the right eye was 3 by 60 with -3 diopter spherical, improving to 6 by 18 and no improvement with pinhole. Left eye was 6 by 18, not improving with glasses, not improving with pinhole. Intraocular pressure measurement with Ullmann applanation tonometer at 10 a.m. on 7th of 10/7/23 was 24 millimeters of mercury in the right eye, 12 millimeters of mercury in the left eye. Central corneal thickness measured with pachymetry was 527 microns in the right eye and 521 microns in the left eye. Corrected intraocular pressure is 25 mm of mercury in the right eye, 12 mm of mercury in the left eye. Gonioscopic examination done by Goldman 2-mirror gonio lens shows the following findings. Right eye, superiorly, angle structures were seen till scleral spur. Nasally, the angle structures were seen till scleral spur. Temporally, the angle structures were seen till trabecular meshwork and scleral spur. Inferiorly, angle structures were seen till trabecular meshwork and peripheral anterior synechiae were noted in the nasal side of the inferior angle. In the left eye, superiorly, angle structures were seen till scleral spur with patent ostium. Nasally, the angle structures were seen till scleral spur. Temporally, the angle structures were seen till trabecular meshwork. Inferiorly, the angle structures were seen till trabecular meshwork and scleral spur. This is the bonogram representation of the angles that have been shown. Fundus was examined with 90D lens, and the stereoscopic view of the fundus is being shown here. Media is hazy due to lens changes. This cup disc ratio was 0.8, vertical cup disc ratio was 0.7, horizontal cup disc ratio was 0.5 to 0.6. There was diffuse neuroretinal rim thinning, and there was nasalization of vessels, bayoneting, and peripapillary atrophy was also present. Vessels appeared normal, maculofoveal reflex was dull, and the fundus was grossly tessellated. Fundus examination of the left eye showed media was clear, disc cup disc ratio was 0.9, vertical cup disc ratio was 0.7, horizontal cup disc ratio was 0.5. There was nasalization of vessels, bayoneting was present, diffuse neuroretinal rim thinning was present, peripapillary atrophy was also present, vessels appeared normal, maculofoveal reflex was dull, grossly tessellated fundus was present. The OCT ONH RNFL findings showed the loss of double hump pattern and the superior temporal and inferior quadrant thinning of the right eye and the diffuse thinning of the left eye. Computerized automated static perimetry done by Blockfield Light of Appasamy gives the following printout. It shows the fast threshold strategy, and the fixation point loss was 4%. False positive and false negative were under 15%. The raw data shows decreased sensitivity over the central test points and the paracentral and the germs area and all over. Grayscale shows the figurative description representation of the raw data. And the total deviation and the pattern deviation. Total deviation showed media opacity defects as well as glaucomatous changes, that is depression all around areas except the temporal iodine. In the pattern deviation, it is shown that the majority of the depression was around central and the paracentral area. In the left eye, the fixation loss was 4% and the false negativity rate was high as it is with the advanced cupping stage. There is generalized depression in the raw data and also represented the same in the grayscale. The generalized depression was also shown in the total deviation graph, and the pattern deviation showed that there is central and paracentral area depression. The overall glaucomatous hemifield testing was outside the normal limit for the both eyes, and the mean deviation was more than 12, minus 12 in the both eyes. My diagnosis would be, it is a case of right eye primary open angle glaucoma with grade 2 nuclear sclerosis with posterior subcapsular cataract with advanced cupping, and left eye primary open angle glaucoma post phacoemulsification and trabeculectomy with mitomycete with releasable suture status with functioning bleb with advanced cupping. Thank you.
Thank you, Dr. Aishwarya. That was a very crisp presentation. I'd like to now request our examiners to please proceed with your evaluation. Dr. Krishnadas, sir.
Okay, Aishwarya, thank you. You said diagnosis as primary open angle glaucoma, and I would start with your investigations first.
Yes,
Why did you say the corrected intraocular pressure was a little 1 millimeter more than the measured intraocular pressure. What was the methodology used to correct the intraocular pressure based on your CCT?
Goldman has given a correction-based formula with regards to the inner corneal thickness. Since it is 520, there was not much of a change from the actual IOP measure and the corrected IOP measures, sir.
Is it actually possible to correct the intraocular pressure based on CCT readings? Is there a nomogram which will give you easy transition? So for so much of thickness, I will deduce so many millimeters, or if it is lesser by so many microns, I will add. Is there a nomogram?
Yes, sir. But currently for this patient, I have used 0.7
Okay.
formula,
There is no linear relationship between the CCT and the intraocular pressure. So
Yes.
it's very difficult to say exactly, precisely. Although there are, you use the GAT, so naturally it is CCT dependent. Are there any instruments which can give you intraocular pressures independent of the corneal thickness?
There will be pulse sir, and tonopen where they can examine without the effect of the corneal thickness, sir.
Oh, Aishwarya, both instruments you mentioned will to a small or large extent will depend upon corneal thickness, just as much as the GAT does. Any other tonometer you heard of, you come across?
What else we use in our glaucoma clinic, ma?
Rebound tonometer.
Is it totally independent of corneal thickness? Although
no, sir.
Okay.
No, sir.
So
it is dependent on the.
You must also know that there are instruments which can. No. Okay. We will also think about it, and these are the things which you can pick up from such interactions and learn. Okay, don't get petrified with these questions. But tell me, what is the importance of corneal thickness in glaucoma?
If there is thinner corneal thickness, then it would record false low intraocular pressure, sir.
Okay.
If there is thicker corneal thickness, then there will be false reading of high intraocular pressure, sir.
Beyond that, yes, you're right. So you need to be extremely careful when you want to interpret it or determine the target intraocular pressures. You need to take corneal thickness into account. Probably it is best to divide corneas as thick, thin, and within normal range, and then try to make a rough guesstimate that you are either overestimating or underestimating the intraocular pressure with all the instruments that you have mentioned, unless you have certain specific tonometers which may give you a CCT independent IUP values. Beyond the underestimating and overestimating, is there any significance to corneal thickness?
Sir is asking you whether CCT is a risk factor or not. Is there any?
Your madam is giving away the answers.
Internals are supposed to give some clues.
Yeah. The internals are supposed to do that.
Yes, sir. It is risk factor, sir. Thinner cornea will lead to increase the susceptibility towards high intraocular pressure.
Yeah.
Sir.
If you have ocular hypertension with thin corneas, that's an additional risk factor
high
for
risk
progression
factor
to
for the
glaucoma.
progression.
And if
Are you
have
aware of any study which proves this point, whatever Dr. Krishna Das has asked you just now? Are you aware of any study?
Ocular hypertension study, sir.
Tell the full name of the
Ocular hypertension child study.
and
BAL.
You're answering well. You're answering well. Go ahead. Be confident.
This is just preparing you for the exam. Even in the exam, you should not be anxious, okay?
Yes, sir.
Do you know what?
Study.
Rotterdam,
Rotterdam study also very important.
what did Rotterdam study say?
That in myopia, that is, there is also low CCT value, low corneal thickness, and it will also cause it will also contribute to being the high risk factor for the glaucoma, progression in glaucoma.
Any idea why thinner cornea should predispose eyes to progression? Do you have any idea? What has cornea to do with the glaucoma progression? After all, glaucoma progression means there is a progressive excavation of the optic discs, ganglion cells. And why should thin corneas predispose eyes to worse progression?
In loss and in glaucoma, there will be considerable endothelial loss, and even in high intraocular pressure, there will be disruption in the side junctions of the endothelial cells, and it will cause corneal edema, which will cause irritation and pain for the patient, and also increase the blurring of vision.
One thing Aishwarya, when we are not sure of the answers, we should not lead the examiners to ask more questions. Aishwarya, relax. If you don't know, you can tell you don't know. Not everybody is expected. Even examiners may not know all the answers for the questions we are asking. That apart, you should not lead the examiners to go dig more and more into area. You should never lead them there. So if you're not particularly sure about anything, you can just tell the examiner, sir, I'm sorry, I'm not aware of this, so that they will go into a new area and ask, in which you may be more familiar and you may be more confident in answering. Okay. So you should also try to find out why eyes with thin corneas tend to progress. Okay. This is the homework for you. And I'm going to come back and ask you.
Yes,
we're not going to leave you at that. Okay. Dr. Shalini and Naik, sir, you can also.
So one thing, because I don't remember now exactly all description that she said, but left eye, can you go back to the slide where the optic disc was described? Can
Please
you
do the slide sharing again? One second.
Because if I remember correctly, it was said CDR 0.9, but vertical disc ratio 0.7, horizontal 0.5. Am I correct in whatever I have?
Yes, sir.
You are right, sir.
Absolutely.
Yes. So
right.
if that was the miss, how come the total CDR will be 0.9, but vertical is only 0.7 and horizontal is 0.5?
And same she said for both the eyes.
Yes.
In
So other
both
eye
eyes
also similar,
Yeah.
0.8 and something like that. So
Right.
so this, because the CDR, the overall CDR is the basically you can say combination of vertical and horizontal.
Yes, sir.
So it cannot be more than whatever the vertical is showing. Either the vertical that you are describing is incorrect. Have you understood what is vertical CDR?
Yes, sir. Yes, sir.
And why which CDR is more important in glaucoma, vertical or horizontal?
Vertical, sir.
Why?
Because the superior and inferior rims are supposed to be thicker than the other parts, sir. But when there is significant thinning in the superior and inferior area, that means there is a significant loss of retinal ganglion cells, sir.
Where does the glaucomatous changes start? Initial changes.
Usually they start as a sectoral area, sir. Probably forming a notch within the cup, sir. You commonly
No,
see
within which area?
inferior
Which area? Which
You
area?
need to say which sector. You're
Sir
right, but
wants
say
to
which
ask,
sector.
yeah, which sector of the
Inferior.
neuroretinal rim? Superior or
Inferior.
inferior, temporal, nasal?
Inferior, ma'am.
Yes,
Right.
that's right, Aishwarya. Go ahead.
Yeah, go ahead, go ahead. No, just some
What do you
hint I will
think?
give you so that in future you can read thoroughly. That
Yes,
the
sir.
initial thing starts in the arcuate area of the retina. It doesn't start from the disc itself. So from there, those fibers, what is the arrangement of the fibers on the disc? Based on that, you develop first, means vertical is more important, the upper and lower. So later on, read in detail.
Yes,
The other thing which I wanted to ask, that in the perimetry,
yes, sir.
it was left eye, cataract has been operated.
Yes, sir.
Okay. What are the causes for generalized depression of field?
Glaucoma, sir, and cataract, sir. Higher stages of
So,
grade 3 and grade 4 stages of cataract, sir. And also it could be neuro related.
Will all glaucoma produce a diffuse problem in a total deviation plot?
yes.
Or some specific type of glaucoma. So in glaucoma, what type of defect we expect?
We will expect tubular field defect, ma'am.
Tubular, yes, it will happen in advanced stage, but in early stage, what type of scotoma we expect in a case of
Paracentral scotomas, ma'am. Paracentral scotomas, accurate scotomas.
Right. So what will happen when total deviation plot shows a diffuse defect? Which type of glaucoma will it be? So it will be a case of advanced glaucoma.
Advanced.
Because in early glaucoma, you will be seeing either a paracentral scotoma or a
Yes, ma'am.
cedrus.
Concentric depression will be seen, ma'am.
Right.
In a moderate, there will be central vision, and in severe, there will be a generalized depression with a small central field or a temporal.
Right.
Ashwarya, yes, in the advanced stage you will get that, but the generalized depression is primarily because of any medial opacity in front of the retina, whether it is in the vitreous or cataract or cornea, somewhere. The other things will not give you generalized depression.
Can you open the perimetry report? Go to the slide
open the
which has.
perimetry.
Please go to the slide which shows the perimetry. Yes.
Because it's I don't know whether this perimetry, I'm not sure whether it is correctly performed, because unless there is medial in the right eye, I can understand, because there is cataract. So you will get a difference in the total deviation and pattern deviation plot.
Yes, sir.
But in the left eye, there is, because generalized depression is because of medial opacity.
But left eye has been already.
Pattern deviation is
advanced.
Have you, this is the first time perimetry has been done, or it was repeated, or it is this?
This was done recently, sir. When I was checking out the case, sir, after 2 months, sir.
Even before the combined surgery, the perimetry was done, but the field was similar to this. It was an advanced glaucoma. What were the false negatives in this field?
54%.
So what does false negative, now this brings to another question. So whatever you are answering, based on that, it's leading to other question. What are the reason for false, means what is the impact of high false negative errors?
It will show a generalized depression, sir, where the patient is unable to see the stimulus that has been shown to him.
Okay, it's not generalized depression, it will show. The one statement you can make for sure is that whatever perimetry we are seeing is means it's basically, it is, means it has, the defects have been enhanced. This only you can say. Nothing more you can say, generalized depression or localized depression or something like that. The high is false negative, but what will the impact of high false positive error?
It would be pale fields, where the patient is enthusiastically pressing even before the stimulus is shown.
No, the perimetry. What will be the effect on, say, whatever perimetry you're seeing?
High normal, so more than the normal value, the values will be there. Sir.
Yes, so the defects will be masked because of the
Yes,
high false positive error.
Yes.
So, okay, now come back to the little on gonioscopy.
Go to the slide on gonioscopy.
Yeah.
Yes, ma'am.
Okay, so now how do you grade or how do you recognize the Schwalbe's line?
With the corneal wedge, sir.
Yeah, so what is corneal? Can you describe? Just describe. I am a layman, so just describe that what is the corneal wedge and how do you recognize that on gonioscopy?
The intersection of the rays that fall on the corneal layers will meet at a point that is where the corneal wedge occurs, and that is where the Schwalbe's line starts. Schwalbe's line is present, sir.
Yes, you are partly correct, but you should clearly mention there will be two reflections you will be seeing from the anterior surface and posterior
The
surface.
posterior surface, yes.
And when these two will meet at a place, then that is the point where it is the starting of the, or that is the Schwalbe's line.
Yes,
so this is how you recognize the Schwalbe's line. And after that, you move posterior in recognizing. What is, why do you call, what is difference between direct gonioscope and indirect gonioscope?
Direct gonioscope, sir, is where the internal reflection is not internal, where the angles are seen directly through the lens, sir, without any internal reflection. But in the indirect gonioscope is where the internal reflection will pass the critical angle and is shown to us with the help of a mirror reflection, sir.
Good. And can you tell me, do you remember in indirect gonioscopes, you used Goldman 3 mirror?
2 mirrors.
Do you know the construction of Goldman 3 mirror? The angles, what are the angles of the, there are 3 mirrors because you're describing 3 mirror. So what are the?
There is a 57-degree mirror, sir. There is another mirror mounted at 69 degrees, sir. And there is another mirror mounted at 73 degrees, sir.
Can you repeat again? What are the 3 degrees?
The one mirror is mounted at 59, 53, 57 degrees, sir. The another mirror is mounted at 69 degrees, sir. Another mirror is mounted at 73 degrees, sir.
I think first time you were right, second time, so you got confused. So be confident in answering. Even if examiner asks you second time,
yes,
if you are confident, don't change your answer because you changed from 57 to 59. Or 59 to 57. And the second one you changed from the 67 to 69. Now, this is something which is, if you, whatever instrument you are using, you should know in detail.
Yes, sir.
And because this is how your curiosity should be generated. Now, this question, if you answer, I will not ask you any question any further. Okay. Where is, whenever we are talking about the angle in the gonioscope,
yes, sir.
So it means there are two surfaces where the angles are formed.
Yes.
Without two surface, the angles cannot be formed.
Yes,
so in this gonio lens, whatever we are talking about the various angulations,
yes, sir.
Then where these angles are formed means what are the two surfaces where the angles are formed? Because the person or the company who is making it must be taking into consideration those things. So do you know that?
One will be mirror, sir, and one will be on the retina, sir.
Yes, one is the mirror, definitely it has to be mirror. Second one?
One is the retina, sir. Our
Retina is not a plane surface. And the person who is making the lens is making the lens in factory. So where is the question of retina coming over there?
central mirror and mirror mounted, sir. Central lens.
So, okay, read this later on. Then as Dr. Krishna Das told you, no, that he is going to come back and ask you whatever he has asked you to read.
Yes, sir.
Okay, and now gonioscope, because you are seeing in the mirror. Usually in the clinic, we are all seeing with the indirect gonioscope.
Yes, sir.
So what should be the quality of good, because purpose of gonioscope is to visualize the angles.
Visualize the angles, sir.
So for good gonioscope, what should be the quality?
The mirrors should be clear, sir, and the coupling fluid should be clear without any air bubbles, sir. And after every use, the gonioscope should be treated with alcohol swipe at the concave part of the lens, sir, and should be kept dry.
No, those things are taking care of gonioscope and fixing it. I am talking about at the level of the means when the various gonioscopes which are sold in the market, some will say that angulation is this much, someone will say angulation is this much, someone's diameter is less, others are a little more.
Yes,
So basically there are certain factors must be, because
handling should be
He has to read for gonioscopes.
yes, so read these gonioscopes in detail.
So,
okay,
Aishwarya, can you move on to your diagnosis slide?
okay, ma'am.
Don't worry, Aishwarya. Okay, just
You're
relax.
doing very good. Yeah,
No,
these
you are
are
doing very
points.
good, don't worry.
You're doing very well.
good.
These are just points so
Yeah.
that you can refine your skills. Okay.
May I request something?
Yes, sir. Yes, sir. Please.
Yes,
So I request the examiners to keep on giving the answers, because this will be on the website for many years and many students may keep on seeing afterwards also. So I think if you are asking the question, it will be better if you keep on answering if the candidate is not able to answer. Whosoever watches afterwards is able to actually know it.
Thank you, sir.
And that also ensures examiners know the answers as well.
Oh, yes, that is correct.
So, Aishwarya, in this particular slide, you have mentioned about releasable
Okay, so
suture.
just a minute, Shalini, one thing, because
Yes, sir.
this Harbans wanted to test whether I know the answer or not. So the angulation between two surfaces is the mirror, as you rightly said, and the anterior surface of the lens. So think over now with this answer, whether whatever I have said. Now the second question, that what is the quality of a good, so that you can visualize easily. One is the height of the mirror, because you are seeing over the hill, angle on the opposite side.
Yes, sir.
So if height of mirror is more, then you will be able to see better. And second is the location of the mirror from the distance from the center of cornea, because farther away from the cornea, the larger then it will be more difficult to see the over the hill from on the other side. But if it is closer to the center, then it will be easily seen the angulation. I mean, the angle on the other side. Yeah, Shalini, go ahead.
Yes, sir. So, Aishwarya, you described about the grading of the bleb, right, in your presentation. So here you have mentioned about releasable suture. So was there any releasable present at that particular time when you examined your patient?
No, ma'am. The releasable sutures are released, ma'am. There was only conjunctival sutures present, ma'am.
So this fact you can tell in your history, because once you are telling the diagnosis, that is the present status of your
Okay,
patient.
ma'am.
And
Okay,
then about the bleb, you have already mentioned the grade, so it should also be mentioned in your diagnosis, isn't it?
Okay,
So how
okay,
do
ma'am.
you grade? What are the parameters for grading of bleb?
The percentage of the bleb height and the extent, ma'am,
Yes.
and the avascularity of the bleb, ma'am,
Right.
and the elevation of the bleb, ma'am.
Very good. Any other thing you to check for the in bleb?
Needle test can be done, ma'am, to see how the leak is, ma'am.
So there is one more thing, microcyst in the present in
Microcyst
the bleb,
presence, ma'am.
right?
Yes.
So that is also an important parameter. Now go to your OCT slide. So I just wanted to ask, why did you perform OCT in this particular patient? And what are the indications of OCT in glaucoma diagnostics?
Because there was a significant filling of the neurorenal rim, ma'am. I wanted to see if the patient still had the double hump pattern or not, ma'am. And the other reasons for
I'm just asking
OCT are
whether OCT is indicated in advanced glaucoma, or what are the indications for OCT? Why did you do in this case, should ask?
Yeah.
to see if there was any viable neuroretinal nerve fiber layer, ma'am, and to see the detailed examination of the neuroretinal limb and the functional structural representation of it, ma'am.
So I'm highlighting this point because in advanced glaucoma, generally when diagnosis is already confirmed, we don't perform OCT in all the patients, right? So what are the three most important parameters for glaucoma diagnosis? One, visual field you did, right?
Yes, ma'am, visual field.
Another one? What is the diagnosis of glaucoma? First tell me, what is the diagnosis of glaucoma?
High intraocular pressure, ma'am. Excavation, loss of retinal ganglion cell layer, ma'am, and visual field defects, ma'am.
So when it is said diagnosis, that means whatever diagnosis is mentioned in the book that you need to tell, isn't it? So you said intraocular pressure as the first factor, but that comes as a most important risk factor, isn't it?
Yes.
So now tell me the diagnosis. From where will you start? It is the progressive
optic
optic neuropathy
with the loss of retinal ganglion cells, ma'am.
So when you say progressive optic neuropathy, then it consists of ganglion cell loss also, isn't it? Now with corresponding visual field defects, where raised intraocular pressure is the most important risk factor. So now your fields are corroborating with your disc finding and you have raised intraocular pressure. So glaucoma diagnosis is already confirmed in your patient, isn't it? So OCT is not indicated in such patients, right? So what do you think, in what patients we should do OCT?
We can see if there is any way to save the eye with the better vision, ma'am. To choose when the both eyes are affected with the glaucoma.
So which stage, I mean, what she's asking is which
first,
stage
when the
it should
patient
be
comes to you and you suspect something,
Whether you'll do it in early glaucomas, where will you do it? Early, madam
Which
already gave you the
stages?
answer, right? This is an advanced glaucoma. Do you really need to do an OCT
Yes.
advanced glaucoma? This is done for the case presentation, right?
Yes.
Right. So you have done this for the case presentation to complete your presentation, right? So otherwise, in advanced glaucoma, you will not do. Okay.
In OCT, there is something known as floor effect. Have you heard that floor effect?
Yes, sir. The neuroretinal will not fall under the minimum level, sir, because there is a laminar fibrosa there.
So do you find anything in OCT of the left eye of the patient? Any problem? What sir was asking about it? Can you focus on the graph, RNFL graph? Now you see.
There is minimum. There is the least minimum level at the nasal rim, and also near the superior rim.
Right.
Now just think, always you are mentioning retinal ganglion cell, ganglion cell, ganglion cell. But this graph is of retinal nerve fiber layer thickness.
Yes.
Means all are correlated, that is different thing, but it is this graph is of retinal nerve fiber layer thickness. So talk about, so mention retinal nerve fiber layer, which measurement is done around the disc.
Okay.
Aishwarya, how will you further manage this patient? You said the intraocular pressure is 24 in the right eye.
Yes,
How do you
sir.
further manage him?
As this patient has reached to the stage of advanced glaucoma couple, sir, I would go for and also the patient has grade 2 nuclear sclerosis with posterior subcortical cataract, sir, subcortical cataract. So I would go for phacoemulsification with trabeculectomy procedure, sir.
Patient says it's just barely 2 months since I've had surgery in the left eye. I don't want to go ahead with surgery in the right eye.
Then I can go for I can add in one more medical therapy, sir. As the patient is already on 2 medications, I can add prostaglandin analogs, sir, in this case.
Why would you do that?
So that we can reach to the point of maximum medical therapy, under which we can see if the IOP is getting under control, sir.
What's your IUP goal in the right eye? Say the patient wants to delay the surgery for 6 months or 1 year. What should be your IUP goal? What do you call it? IUP goal?
Target IOP, sir.
Target IUP. Good. How do you determine it? And what is the best estimate of the target intraocular pressure in the right eye?
We determine it according to the stage of the glaucoma, sir. Mild glaucoma, moderate or severe glaucoma, where the intraocular pressure, visual field effect, and the RNFL layer will be taken into consideration, sir. As this is an advanced case of glaucoma, the target IOP would be under 12 mm of mercury, sir.
Okay. How do you classify as mild, moderate, or severe?
Yes, sir.
How do you classify the grade? How do you grade the glaucoma as mild, moderate, severe? You said I would do it based on visual fields. And what else? We don't typically do it based on OCT. It would be very difficult. You need to really quantify. We don't have that standardized quantification based on ONH features or RNFL features as yet. That's a good area to research on. But currently, what parameters or what data inputs would you use to grade severity of glaucoma?
Disc damage likelihood scale.
Based on visual fields, how do you said that, right? Mild glaucoma, moderate glaucoma, and severe glaucoma. So based on visual fields, how will you classify it as mild glaucoma, moderate glaucoma, and severe glaucoma?
For instance, what makes you say this is an advanced glaucoma? What are the reasons to grade this right eye as advanced glaucoma?
Because there is a
Are both the hemifields
Yes.
involved? Is there
yes,
involvement
ma'am.
of the high degree?
Yes, ma'am. The based on the Anderson.
grading, ma.
You just tell us the point. Don't go for the values because it's very difficult to remember everything.
Yeah.
At each stage. If you can elaborate us 2-3 points in the fields which you see for the severity of the glaucoma, that is good enough for you.
Yeah. Just recall what is mild, what is moderate, what is severe.
If there is only a part of few degrees of loss of visual field near the paracentral area would be considered as a mild glaucoma. If the visual field loss is over a hemifield, almost an arcuate type of visual field loss would go for a moderate level, sir. And in the severe level, more than 50% to more than 75% visual field loss is present only with a central field of vision when that is advanced.
Are you aware of any index which can tell you that the defect is mild? Just the number. Any index are you aware of?
Visual field index can be.
No, even the visual field index, yes, and other things means in the classification of the mild, moderate, severe glaucoma. What is the difference between MD? What is MD?
Mean deviation, sir.
So on that basis, is there any classification? Can you just broadly, can you think of that? Anything? Okay,
mild,
just
moderate, advanced, and very advanced.
No, sir is asking based on mean deviation, can you grade?
number,
How much of mean
number.
deviation is
Just a
mild?
rough
How-
number. So
Yeah.
She got confused. She said a number in the evening, no? That's
So you get numbers in minus if you have
yes,
a
ma'am,
of
mean
glaucoma.
deviation.
So what
if
is
it
that
is-
number?
If it is less than -10, then it would be a mild to moderate type of glaucoma, ma'am. And if it is greater than -12, it would be advanced type of glaucoma, ma'am.
now, if it is simple thing to remember, less than 6 is mild, 6 to 12 is moderate, and more than 12 is severe glaucoma. So this is simple. Otherwise, the other factor also what your mentors were suggesting, that the location of the points in the center. So those things you forget, but this one broadly you remember. Just one thing more on perimetry. What is the difference between VFI and mean deviation, MD?
Visual field index would be expressed as a percentage, and it would be seen over few analyses, while the mean deviation is the deviation of the patient's retinal sensitivity from the normal values of general population.
No, one thing I will just again, Harbans Lal
Yes,
wanted
sir.
answer. So, so VFI, visual field, there are 2-3 differences between MD and VFI. One is that in MD is range is very narrow, means it's up to maximum, it cannot go more than 32,
Yes,
-32.
yes.
So range is 0 to 32, whereas VFI is calculated 0 to 100. So it's a larger range, so it is more sensitive for change, number one. Number two, the percentage which is calculated, so more central points which are more important are given more weightage. So it has got more functional value, importance. And the third thing, that because of just now with the initial question which I had asked, the generalized depression will not affect, because if a glaucoma patient is also developing cataract, there will be generalized depression. So MD will deteriorate, but VFI theoretically should not deteriorate. So the effect of generalized depression does not affect visual field index. Okay. Yeah, go ahead now. In the treatment part, what Dr. Krishna Das was asking, now, what will be the effect of intraocular pressure on intraocular pressure, only cataract removal?
It would be, it would decrease the, you know,
It will decrease. No, that's correct. You are telling is correct.
How much decrease you expect after cataract surgery?
minimal decrease, ma'am. I don't know the exact percentage of how much it would decrease.
Okay. Are there any conditions where cataract extraction will cause significant decrease in intraocular pressure?
Phakomorphic glaucoma, sir, lens-induced glaucoma,
Good,
where the removal of the lens particles would decrease
Okay.
a lot of eyes.
That's nice. That's a very good answer. Anything more?
Very well answered.
Is there any other lens related glaucoma, not induced, or partly induced, lens related primary glaucoma that will significantly be benefited by lens extraction to some extent?
Phacolitis glaucoma, sir.
Yeah, you said lens induced,
Yes.
phacolitis.
Lens induced.
Any other primary glaucoma that may be
Angle closure,
significant?
angle closure
Excellent.
glaucoma.
Excellent, excellent. You need to know the role of lens in pathophysiology of angle closure.
Okay.
That crystalline lens has a huge significant role to play in pathophysiology of angle closure glaucoma.
Yes,
And you should also understand when lens extraction will contribute significantly to intraocular pressure reduction in eyes with angle closure glaucoma. That's totally separately a different topic altogether. But coming back to the treatment again, Prashant, you should stop us when we run out of time. We
So
keep
we
asking,
can
but
complete
Yeah,
the case.
Close
More than time, I think we can have the general discussion about this case in another 10 minutes so that
Okay.
people will understand what are the maximum
know.
questions can be answered on this topic.
Exactly. So why do you want to add medication? And when you said add medication to reduce the target intraocular pressure, what medication you will add? He's already on 2 medications.
Yes, sir.
What medication you will add?
I would add prostaglandin analog
Okay.
for this patient to give a longer acting action and
Is
more
that the
relief.
only advantage? Or what are the other advantages of prostaglandin analogs?
They would also increase the uveous scleral outflow, sir. And
so what are the considerations you will have when you want to add or switch to medications? What are the general considerations? What are the medications you would prefer to add or switch, or what are the medications you would avoid? A direct question, let me ask you. Why can't I add dorzolamide? Topical dorzolamide to this eye, the right eye. You can add, but why is it preferable to add prostaglandin analog rather than dorzolamide?
there will be a minor reduction of intraocular pressure when compared with the prostaglandin analogs.
Okay.
And there would also be the dosage of the medication also.
Excellent, excellent. Any other reason?
Also, there will be lesser side effects when compared with the dorzolamide to the prostaglandin analogs.
And what is the major advantage?
What is considered to be the first line of treatment?
Prostaglandin analogs.
Yes, and the reasons already you told just now. Single dosing plus the effect is maximum. No other medication has got so much effect theoretically.
Yes, sir.
And reported and the least side effect.
Yes, sir. And the compliance will be high, sir.
Yes, compliance will be high because of these reasons, that the side effect will be less, and single he has to use only once. Yeah, okay. Yeah, Krishna Das, go ahead.
Any other major advantage of adding prostaglandins apart from what you and Naik sir added? So
situation of
he's
inflammation.
Yes, please go ahead.
In situation of inflammation, it will help with decreasing.
No, in this particular patient, that's theoretical, hypothetical in this particular patient. So Aishwarya, he's already on 2 drugs, timolol and brimonidine. What is the mechanism of action of timolol? What is the mechanism of action of brimonidine?
Both of them decrease the aqueous production, sir.
Okay.
They act on the clamp receptors in the ciliary body, sir.
Okay.
Beta
And how
blockers
does
and
dorzolamide act?
alpha-adrenergic. They inhibit the carbonic anhydride receptors.
Okay,
So
the net effect of all these 3 medications is suppressing the inflow. So the question is, how much will the aqueous can be suppressed? Beyond a certain limit, it will be very difficult to reduce aqueous secretion, isn't it?
Yes, sir.
So you need to look for drugs that will reduce the intraocular pressure through other mechanism of action. What are the ways by which intraocular pressure can be reduced? One is aqueous reduction of aqueous inflow. Is there any other way you can reduce the intraocular pressure?
By increasing trabecular outflow, sir.
Outflow.
And
How
also,
do you increase trabecular outflow?
By prostaglandin analogs, sir.
No. Does prostaglandin increase trabecular outflow? What is a no? What there are some claims. We will leave that. What is the principal mechanism by which prostaglandins reduce intraocular pressure? So let me ask you, what's increased trabecular outflow? If not prostaglandins.
Sir, you are correct that it's increasing outflow. Sir is asking what is another mechanism apart from trabecular by which you can have more outflow?
Sympathomimetics can mechanically open the trabecular meshwork, sir. That will increase the trabecular meshwork outflow, sir.
So what are the sympathomimetics? No? Do they increase the trabecular outflow? What are the
pilocarpine?
how does pilocarpine act? Where do you classify pilocarpine? What kind of drug is pilocarpine?
It will also, it's sympathomimetics. It will.
Para.
Yeah.
I think she has been grilled enough now.
Enough.
Yeah, no. That's not the idea. No, that's not the idea. The idea is to encourage them to read. She's only the 2nd year now. So the idea is to make her understand and read and apply. That's the idea. I know it's very difficult for postgraduates these days, not like our days, when the information was much contained and lesser. Now it's just knowledge explosion the past 2 decades. No? So they have so much to read, so much to know, so much to understand. It should actually be a 5-year course rather than a 3-year course.
Thank you. I think
after 60 minutes of presentation and Viva, I think everyone is lost, not her, even anyone can lost. So
yeah.
He's asking for the another outflow, Dr. Aswara. It's UV scleral outflow by which
yes,
you can.
scleral outflow.
Yeah, very good.
I think she answered very nicely, and she is a very good student, I would say. And majority of things she has read, few improvisations are needed, and I'm pretty sure by the exams she will be reading everything and doing wonders in her exams.
Dr. Aswara, you stop your PPT slide, so then we have some sort of discussion, common questions for the another residents who are with us, joined us with chat and everyone. So
I think before we go ahead, I think my heart goes for this Braveheart girl, and she deserves a 3 round of applause from all of us. She's just
Wonderful.
14 months into ophthalmology, 15 months into ophthalmology. She still has 16 months more to finish her ophthalmology. No, not 16, even 18 months more, I believe. So she really answered all the people with an experience of 35 to 25 years of experience, and she answered almost 70-80%. So that's why all of us should definitely clap for her before we proceed.
In fact, sir, experience of our experts are more than his her. That is the best thing you can say. But not only Dr. Sarmila, but her mentors too. Both of them worked hard so that we understand how is the teaching and training at RIO Chennai. So good, ma'am, Professor Sarmila ma'am and
Thank you, sir.
Dr. Sarmila Devi. And Krishna sir, your 2-3 comments how to manage it, as if it is your case, how will you manage it, just for the acknowledgement to the students, they can know what is the right way to manage this case.
I think the left eye, this person has fairly advanced glaucoma with a significant amount of cataract. So rightfully, he has undergone a glaucoma triple procedure, and it's only 2 months, but the intraocular pressures are very low, 12 millimeters. And even for very early glaucoma triple course, this is a very good intraocular pressure that we could obtain. And I guess mitomycin was also used. So even in the next few weeks to months, if intraocular pressure tends to rise because of increased fibrosis, there are always possibility of suture lysis, because I think the apical suture is still there, or the possibility of blood needling in future. That is as far as the left eye is concerned. Now, as far as the right eye is concerned, we agree with Aishwarya that the intraocular pressures are still not a target. And I agree with that, we should plan for an early glaucoma triple procedure at the right eye, because going on adding and switching medications for a long term is going to affect the outcomes of the filtering surgery in this eye also. So one fixed combination, brimonidine timolol or dorzolamide timolol, is good enough to start with, and we can buy some time. But since the intraocular pressures are still 24, which I would think we would require at least 30 to 40% reduction. So the only alternative is to either add prostaglandins or plan glaucoma triple procedure. And I feel that lesser the medications are used, and for lesser the duration the glaucoma medications are used, we begin to understand now that early intervention goes a long way in ensuring filtering surgery success. So we are lucky in that he also has operable cataracts, and doing glaucoma triple is not only going to improve his visual quality of vision immediately, but the likelihood of long-term filtering success is also likely to be better. So as far as this person is concerned, I agree with Aishwarya that we should plan for an early glaucoma triple procedure at the right time.
Thank you, sir. Now, sir, Dr. Nayak, sir, lots of PGs are watching. Can you give us 3, 4, or 5 important clues when they are going to read a visual fields, what they have to look for that in a Humphrey fields? What are the important points they should not miss? Although it's a very long discussion, but
Dr.
just as a
will
point,
take a class for 2 hours on the visual field.
that's why, sir,
That's why it is not a topic. It is not a topic of 2 minutes. In fact, I suggested Prashant Bhavankule to have the faculty talk for 15 minutes and do not keep the perimetry, because it cannot be taught in 10-15 minutes. Actually, it needs a lot of time. And secondly, I wanted him to keep the gonioscopy or something by the faculty. And I definitely request, I think it's enough so far as the today's class is concerned. And we definitely thank all the faculty and all the moderators and the presenters, member ARC and the chairman, for starting on a very bright note and having first session really going very well. But at the same time, I will also like to add over here, because the students, we also need to present something to the students so that they keep on picking up from us also, instead of just asking. So in the future, I requested him to one of the faculties should present at least the gonioscopy part of it, so that the people can see and understand better. So I request, this was an excellent presentation by the Ashra and very well conducted and discussed. It's a very long topic. I mean, you can't finish off the glaucoma discussion in 1 hour, but I think it's a good beginning and we can take up the other topics later on. And with this, I think we should end this session. And thank you everyone for being here. And next time I'll request that keep a talk for 15 minutes of one of the faculty as well.
Sure.
Thank you very much.
That's a good idea. That's
Thank
a
you,
good
Prashant, you
President,
want to
sir.
say anything?
Yeah.
Prashant, you want to say anything?
Yeah. Thank you, President, sir, for those suggestions. Those suggestions will be taken in the right space. This was the inaugural episode. We are learning from it, and we will be taking into consideration that faculty small tips from the next thing. For the sake of the viewers, again, we are going to have a PG activity on the coming Thursday at 8 p.m. That time it is going to be a journal club. 2 journals based on glaucoma will be presented by the 2 postgraduates along with their mentors, and there will be 3 discussants who will be doing it. So be on a watch out. We will be trying to improvise and adding more spice and more knowledge to it. I hope with this, I would once more take this opportunity to thank Dr. Krishna Das sir, Dr. B.K. Nayak sir, and Dr. Shalini Mohan for agreeing to spare time for these young students and trying to make these students understand what is the examination process, what goes on in the minds of the examiner precisely, and what is the type of a question, even in a simple case like a glaucoma, how it can deviate, what they should answer, what they should not. Similarly, thank you, Professor Sharmila ma'am and both Sharmila ma'ams for accepting to be getting their student here, mentoring them so well. And more importantly, 3 cheers once more to this young girl, Aishwarya. And of course, my team, everyone.
I will add one more thing.
Yeah.
I always tell my students that just think questions before you go for the presentation. If you suppose you are on the other side, what question you are going to ask the student? So that way you are already prepared for some of the questions, at least if you were the examiner, what questions you are going to ask this. So you are already prepared mentally, what are the questions to answer.
So these are some pearls of advice for you, Aishwarya, and the postgraduates who are watching. How you should read into the minds of the examiner and not let it deviate. And they should not carry the discussion. You should lead them to the discussion, the subject which you know better. That's what even the clue Dr. Krishna Das sir and Nayak sir had also suggested during the course of it.
Secondly, even there is no hesitation in saying, I don't know, sir. And if you are guessing it, you can always excuse yourself before and can I make an intelligent guess? So that means examiner already knows. If you say just go ahead, you go ahead. Otherwise, you can say I don't know. So there is nothing wrong in saying I don't.
Well, that's the beauty of it. Thank
Sir,
you.
all of us
Bye-bye,
from
everybody.
RIO are very grateful to you, Sir President, sir, and the entire ARC team for choosing RIO for the first session, sir.
So
Nice of you, and it's really very interesting to us also to sit and discuss with all experts in the field. It's really nice. Even we learned a few points today. Thank you, sir.
Thank you.
Okay,
and one thing I will add, the purpose of this exercise is to basically so that stimulate the candidate to read more. But in the final exam, the purpose is to know how much they know and basically the passing. Yeah. So here maybe we may be probing little more because we want them
that's perfectly all right, sir. I think you did a wonderful job and you are a great teacher. There is no doubt about it. And your understanding of glaucoma is superb. I've heard a few of your lectures. I'm really impressed. Thank you, sir.
Thank you. So it's time for us to say goodbye from our team ARC. On behalf of team ARC, we are thankful to each one of you, all the GC members, all the examiners and the mentors, and of course the mentee who played the vital role today for today's discussion. So let's meet again on following Thursday. That is going to be 20th at 8 p.m. for the Journal Club. Thank you once more. Bye-bye.
Thank you so much.
Thank you everyone and good night.